We can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Okay, we start now. Good afternoon, everybody. Today we have three sections first, and now the education course number 4. Co-chair with me, Dr. Sanraya Viswamitra. Me, Professor Hoàng Minh Lối, President Congress. And now, Dr. Sanraya, you introduce yourself.
Good afternoon and welcome to the annual Congress of the 14th ASCI Congress. It gives me great pleasure to be invited as a co-chair. My name is Sanjaya Vishwamitra and I'm from India. Back to you, Dr. Minhoy, to introduce the first speaker, please.
Thank you, Dr. Sanraya. The first topic will introduced by Dr. Karen Ordovas from USA. She professor of radiology, section of cardiothoracic imaging at University of Washington, with the specialty advanced cardiac and pulmonary imaging, in particular cardiovascular MR and CT. And she has the Fellow Society of Cardiovascular MRI and ASCI, and North American Society of Cardiac Imaging, and ASCI, and has past president of ASCI and chairman of ACR of Cardiology Research Committee. Now she will present topic hypertrophic cardiomyopathy. Please, Dr. Karen Ordovas, please.
Greetings, everyone. My name is Karen Ordovas. I'm a professor of radiology at the University of Washington. and I'm here representing the North American Society of Cardiac Imaging to talk about CMR and hypertrophic cardiomyopathy. I have no disclosures. The outline of this talk will start with diagnostic role of CMR for hypertrophic cardiomyopathy, particularly focus on when it aids value to echocardiography. And then we'll discuss prognostic applications of CMR for risk prediction of sudden cardiac death in hypertrophic cardiomyopathy. Again, the focus is in added value to echocardiogram. What are the diagnostic features that we look on a CMR examination when suspecting the diagnosis of hypertrophic cardiomyopathy? The key feature is, of course, the presence of hypertrophy. And based on most recent guidelines, any area of wall thickness higher than 15 millimeters without a pressure overload lesion to explain the hypertrophy will be diagnostic of hypertrophic cardiomyopathy. That threshold is a little lower, 13 to 14 millimeter, if you're dealing with patients that have a family member with hypertrophic cardiomyopathy or a positive genetic test. The other feature that is characteristic of hypertrophic cardiomyopathy is the presence of left ventricular outflow tract obstruction. And finally, another feature that contributes to diagnosis of the disease is finding a typical late gadolinium enhancement pattern that is particularly seen in this disease. These are the classic types of hypertrophic cardiomyopathy that have been described. We're looking for either a sigmoidal type of hypertrophic cardiomyopathy when the septum looks inverted or kind of outpouching into the outflow tract where the maximum hypertrophy is. Sometimes you see a reverse curve subtype in which the entire septum is hypertrophy. Minority of cases are going to be apical type of hypertrophic cardiomyopathy, and finally the neutral type, or what some people call symmetric type of hypertrophic cardiomyopathy. So any of these phenotypes can be identified with cardiac MRI. Recently, a large registry, including United States and European sites, describe distinct subgroups of hypertrophic cardiomyopathy that are in addition to these classic morphologic features. What was described in the study was a presence of a basilar predominant pattern or hypertrophy just in the base of the septum, entire septum with a reversal of the curvature of the septum, predominance in the apex, number 4, which is concentric, and finally they also describe a mid-ventricle predominant pattern with apical aneurysm, and another feature that was described as other, because the hypertrophy was quite unusual and wouldn't fit any other pattern. That summarizes how diverse can be the presentation of hypertrophic cardiomyopathy in a large subset of US and European population. So let's look at a few examples of imaging findings. I'm showing you a steady state free precession cardiac MRI in the short axis plane. And in this case, the maximal wall thickness was very large, higher than 15 for sure, approaching what's characteristic of a high severity of disease, which is 30 millimeters. That's a high feature, a high risk feature in patients with hypertrophic cardiomyopathy. It can be very precisely characterized with CMR. Now, CMR usually confirms the diagnosis of hypertrophic cardiomyopathy whenever there is an unusual distribution on echocardiography or that method is inconclusive. There are few locations in the cardiac segmentation regions that echo can be blind for. Those are called 2D echo blind areas, and classically they are described as the anterolateral free wall, the apex, the posterior septum, and I'm going to show you examples in a minute of how echocardiography may not appreciate the diagnostic features of hypertrophic cardiomyopathy when this distribution is present. Another feature where CMR can add value to echocardiography is to differentiate tumor from other mimics of hypertrophic cardiomyopathy. and finally aids on prognostic characterization of the disease. Here are examples of potential echo-blind areas. Patient has severe hypertrophy of the posterior septum that was underestimated on echocardiogram. Echocardiogram only could visualize the anterior septum, so you can see there is a big discrepancy between those two septal regions. An interesting meta-analysis looked at the concordance or the agreement between CMR versus 2D echo on the areas of maximum hypertrophy and what areas were considered blinded for echocardiography. So there's a fair percentage of cases in several studies that were collected in this meta-analysis that were only seen by MRI. And the most frequent locations for that are described here and are pretty similar to the locations I just described. Here's another example of some echo-blind areas and the respective CMR. This is a patient that has hypertrophy of the anterior wall, and look at this CMR examination showing much thicker segment. Here is another patient with similar distribution anterolateral wall, measurements with echocardiogram, and significantly bigger measurements with CMR. Now I'm showing you an example of steady-state free precession cine images at 4 different levels on a young Asian male that presented with arrhythmias. And I want to call your attention to the apical level. You can see that there is significant hypertrophy at the apical level, and there is cavity obliteration during systole. Those features are characteristic of apical type of hypertrophic cardiomyopathy. This vertical long axis view exemplifies it even better when you can see the focal hypertrophy in the apex and cavity obliteration. Sometimes you're going to see a mid-cavity obstruction associated with an apical aneurysm, and this may be missed on echocardiogram. So another way that CMR can add in characterizing these diseases morphologically is to identify the apical aneurysm. A study including more than 1,000 patients with hypertrophic cardiomyopathy showed that apical aneurysms are in fact rare, but they are frequently missed on echocardiogram. In this examination, only 2% of patients with hypertrophic cardiomyopathy had apical aneurysm, and it was detected in approximately 60% of the cases on echocardiogram. Here's a feature of one example of a left ventricular image on echocardiogram and how the apical aneurysm was missed, and it's clearly present on CMR. One more example on how CMR can add value on the characterization of hypertrophic cardiomyopathy is this case when we have a 28-year-old woman presenting with a septal mass on echocardiogram. Black blood images before and after gadolinium show severe hypertrophy of the septum, but notice how there is enhancement that is very different than the remote myocardium. When you see this pattern of gadolinium enhancement, consider that it could be an angiosarcoma mimicking hypertrophic cardiomyopathy, as it was in this case. Different example here showing what should happen with myocardial enhancement in a patient without cardiac tumors and just hypertrophic cardiomyopathy. Before and after gadolinium, you have homogeneous appearance of the septal signal intensity relative to the remote myocardium. Another mimic of hypertrophic cardiomyopathy is this particular disease. So you see what's apparent hypertrophy at the level of the apex on echocardiogram. But with MRI, you can clearly characterize that there is indeed hypertrophy, but there is this classic subendocardial late gadolinium enhancement, which is characteristic of endomyocardial fibrolastosis. Another mimic that can be seen on echocardiogram and better characterized with cardiac MRI. Now let's switch gears and talk about the prognostic role of CMR in hypertrophic cardiomyopathy. CMR adds value in establishing risk by providing precise measurement of the wall thickness and mass, detection and quantification of areas of late gadolinium enhancement, and identification of apical aneurysms. This slide shows you a classic way in which the risk of sudden cardiac death is predicted in patients with hypertrophic cardiomyopathy. It looks at the ACC ASCI guidelines from 2011 and compares the two guidelines in terms of discriminating what patients would have sudden cardiac death. The risk factors that are usually included are family history of sudden cardiac death, non-sustained ventricular tachycardia, unexplained syncope, severe hypertrophy, abnormal blood pressure response to exercise. And you can see how both guideline criteria have a very similar ROC curve and are able to discriminate disease, but they're not close enough to the diagnostic power expected to decide what patients would need defibrillators as a primary prevention. Now let's look at this diagram that kind of helps understand how we approach a patient with hypertrophic cardiomyopathy to decide if you're going to give the patient a defibrillator to predict sudden cardiac death as primary prevention. For secondary prevention, after a patient has had a cardiac arrest, it's clear the patient needs ICD, but for primary prevention, the risk factors I just presented to you are weighted, and the patients are then classified in high risk, intermediate risk, and low risk. It turns out that patients that are in intermediate risk can be reclassified based on the presence of specific features on imaging, and that's where CMI plays a role. So if patient is end stage phase or has the presence of a left ventricular aneurysm, extensive delayed gadolinium enhancement, or marked LV outflow obstruction, these patients may behave instead as a high risk and be eligible for defibrillator treatment. Let's look at how late gadolinium enhancement presents on hypertrophic cardiomyopathy. Up to 80% of the time, you're going to see abnormality in the area of maximum hypertrophy, as in this example, where you see very impressive thickening of the septum with extensive late gadolinium enhancement. The other common site that is characteristic of hypertrophic cardiomyopathy is late gadolinium enhancement in the anterior and posterior hinge points, or the right ventricle meets the left ventricle. This is an example of a patient with an unusual form of hypertrophic cardiomyopathy, apical hypertrophic cardiomyopathy, where you can see very thick apical myocardium and extensive areas of late gadolinium enhancement in the area of maximum hypertrophy. Now, please note that when we're dealing with this disease, sometimes the late gadolinium enhancement may have a lower intensity than what we typically see with myocardial infarction. These are two examples, a patient with apical HOCM and a patient with asymmetrical type, in which there's faint areas of late gadolinium enhancement in the areas of maximum hypertrophy. So the presence of late gadolinium enhancement was shown to predict cardiac mortality, all-cause mortality, and heart failure death in this population. A meta-analysis that includes the most important studies investigating the role of CMR to predict sudden cardiac death, including more than 1,000 patients, showed that about 60% of them have late gadolinium enhancement. Notice that the pooled odds ratio for adverse cardiovascular events was calculated at approximately 4.4 for all-cause mortality. That means that if a patient has late gadolinium enhancement in the setting of hypertrophic cardiomyopathy, patient has more than 4-fold chance of having adverse cardiovascular events compared to those who do not have late gadolinium enhancement. A different study published in 2017 enlightened us even more on the extent of late gadolinium enhancement and how that affects outcome. The study did a survival analysis based on percent of myocardial scar, included 1,293 patients, and the outcomes they were looking at were sudden cardiac death and progression to heart failure and transplant. Now notice the survival curve, and you can see that as the percent of late gadolinium enhancement increases, there is worse freedom from event. This percent LGE is a new parameter that indicates the percent of the myocardium that is enhancing relatively due to the entire mass of the left ventricular myocardium. It turns out that approximately at equal or more than 15%, that's when patients start having an acute increase in the number of events. From this publication, we learned that There's a 10% increase in LGE associated with a 40% increase with relative sudden cardiac death risk. So the current approach to use MRI in this risk characterization is to use the percent late gadolinium enhancement to reclassify these patients. Patients with a low risk status can then, with the presence of late gadolinium enhancement, be considered high risk status. A study by Dr. Merriman and his group looked at a particular cohort of patients and found 21 of 37 patients with events that were absolutely low risk based on common risk factors, but had late gadolinium enhancement and would therefore have been identified as high risk if CMR had been performed. So there is risk increase in the presence of late gadolinium enhancement. Another feature that can be used for prognostic characterization is the presence of an apical aneurysm. This is the largest study that looked at survival free of adverse events in patients that did have an aneurysm in blue or did not have an aneurysm in red. And you can see that those with aneurysm had a much higher event rate. Threefold increasing mortality and thromboembolic events compared to those without aneurysm formation. The most recent guideline published in 2020 by the American Heart Association and the American College of Cardiology have focused on the role of MRI in primary prevention, particularly in those risk modifiers. As a level 1 recommendation, CMR is now indicated for use in patients for which high-risk features are not otherwise identified or that a decision to proceed with ICD placement remains uncertain. What are the features in CMR that increase risk? Late gadolinium enhancement extent, presence of an apical aneurysm, a low ejection fraction, and a significant wall thickness. So in summary, CMR adds value to echocardiography for diagnosis of hypertrophic cardiomyopathy, and it's most useful in what's called the echo blind areas. And there is an increasing role of CMR as a prognostic tool for primary prevention in patients with hypertrophic cardiomyopathy. It's a risk modifier now considered in the most recent American guidelines for ICD implantation as primary prevention. Thank you very much for your attention, and it was a pleasure to be here at the Asian Society of Cardiovascular Imaging.
Thank you, Dr. Ordovas. That was an excellent presentation, and you walked us through a lot of key and important features of hypertrophic cardiomyopathy. It gives me great pleasure to introduce our second speaker, Dr. Noriko Oyami Manaba from Japan. She is a professor in the Department of Radiology at Jichi Medical University, Satama Medical Center. Her academic appointments include the Japanese Society for Magnetic Resonance and Imaging, SCCT, ASCI, Asian Society of Cardiovascular Imaging, and the American Roentgen Society. She has had prize-winning lists in 2010, 2011, 2017 in multiple different conferences and has received the Certificate of Merit Awards, the Best Moderated Poster Award as well. She will be speaking on amyloidosis and sarcoidosis. Dr. Noriko, over to you, please.
My name is Noriko Oyama Manabe from Jichi Medical University, Japan. This is today's overview. I am going to talk about both cardiac sarcoidosis and cardiac amyloidosis. Let's start with cardiac sarcoidosis. Sarcoidosis is a multisystem granulomatous disorder of unknown etiology. It is characterized by non-KCHN granulomas. Typically, young or middle-aged adults are affected. Bilateral hilar lymphadenopathy. Lung, skin, joint, and eye lesions are well-known involved regions. Essentially, all organs are able to be affected, including the heart. Prognosis is related to the presence of cardiac lesions. Cardiac sarcoidosis is the major cause of death in patients with sarcoidosis. The frequency of cardiac involvement varies and is significantly influenced by race. Autopsy studies in the United States have revealed a frequency of cardiac involvement of about 13 to 50%, whereas autopsy studies in Japan have shown a frequency over 50% up to 85%. Myocardial biopsy is specific, but low sensitivity. Therefore, non-invasive, accurate diagnoses are needed. This is the New Japanese Society of Sarcoidosis and Other Granulomatosis Disorders criteria, revised in 2015. FDG PET and rate gathering enhancement were included in major criteria in the new version. The Heart Rhythm Society of the United States proposed the following criteria for diagnosis and management of cardiac sarcoidosis. FDG PET and MRI are recommended for sarcoidosis patients with any history of cardiac diseases or ECG or echocardiography abnormality. Guidelines also suggest screening for cardiac sarcoidosis in younger patients with unexplained advanced heart block. Next, diagnostic imaging of cardiac sarcoidosis. I will talk about FDG PET first and then cardiac MRI. I will show you several uptake patterns of the myocardium. Most popular methods for visual analysis. Uptake patterns are divided into 4 groups. Without myocardial FDG uptake is considered to be negative. Definite diffuse uptake in the entire LV wall generally thought to be physiological and does not indicate an abnormality. Focal and focal diffuse FDG uptake in the LV wall is considered to be positive. We need to know the pitfall of FDG PET. These are follow-up images obtained from the same patient with malignant lymphoma. Please pay attention to the cardiac uptakes. The pattern of cardiac uptakes were various at each scan. We published our protocol for FDG PET preparation. For suppression of physiological uptakes, patients were introduced at least 18 hours fasting with low carbonate prior to FDG injection. This is our special low-carb meal with egg, tofu, and chicken for preparation. FDG PET is useful not only for detection of the cardiac sarcoidosis, but also for monitoring the response to anti-inflammatory therapy and early recurrence. This patient responded to steroid therapy at first. However, you can see the recurrence. Next few minutes, I will introduce cardiac MRI. This is the protocol for sarcoidosis. This is a schema of gadolinium enhancement in cardiac sarcoidosis. In normal myocardium, myocardial cells are high dense and interstitial space which can be enhanced was very limited. The infiltrated granulomas in the active phase of cardiac sarcoidosis are well enhanced after gadolinium injection. The scar formation with fibrosis in the chronic phase is well enhanced due to the spread of the interstitial space. Rate gadolinium enhancement patterns tell us the etiology of the disease, allowing differentiation of ischemic versus non-ischemic cardiac diseases. Sarcoidosis mainly shows epicardial distribution. However, various enhancement patterns can be shown. This case shows transmural enhancement in the inferior wall and mid-wall enhancement at the interventricular septum. In the right image with fat suppression, you can easily see the RV wall involvement. Since the RV wall is thin and difficult to be distinguished from epicardial fat, fat suppression is important. You can see the difference in patient outcome with LGE extent at a cutoff value of 20% of myocardium. The extent of LGE is a significant predictor of adverse outcome in cardiac sarcoidosis patients. My clinical and research experiences in cardiac sarcoidosis were published as state-of-the-art review in Korean Circulation Journal. This article included systemic reviews about the diagnostic ability of FDG PET and CMR. The combination of both modalities achieved the very high sensitivity. This is a radiology paper about T1 and T2 mapping for cardiac sarcoidosis. Native T1 showed the highest sensitivity and specificity. T1 and T2 mapping may enable recognition of cardiac involvement and activity of myocardial inflammation in patients with systemic sarcoidosis. Regional strain analysis using feature tracking can be applied retrospectively to existing cine-CMR images without contrast material. This case highlights that cine-MRI-based strain analysis may help to identify RV involvement in patients with cardiac sarcoidosis. I would like to introduce the potential of CT. Delayed contrast enhanced CT, DCT, can be applied to patients with implantable devices. We have reported that DCT can detect cardiac sarcoidosis similarly to cardiac MRI. DCT shows high sensitivity for detecting cardiac sarcoidosis. DCT may be useful particularly in patients with contraindications to cardiac MRI. Next, I will talk about cardiac amyloidosis. Although more than 30 types of protein can cause amyloidosis, only 2 types commonly deposit in the ventricular myocardium: amyloid light chain (AL) and amyloid tricylitin (ATTR). Here are schemas of amyloid types. AL amyloidosis is a plasma cell dyscrasia that is often treated with chemotherapy or stem cell transplantation, whereas ATTR amyloidosis results from the production of abnormally folded transthyretin in the liver. Light chain AL amyloidosis is the most common form of systemic amyloidosis, accounting for 70% of patients with amyloidosis. The most frequently affected organ was the kidney, followed by the heart. The left figure is the world distribution of transthyretin familial amyloid polyneuropathy. The size of the circles is proportional to the number of patients. The right figure shows different amyloidogenic mutations reported in Japan. Prognosis in amyloidosis is dependent on the degree of cardiac involvement and, in AL amyloidosis, on circulating left chain levels. Because chemotherapy options have greatly expanded in recent years, prognosis for AL amyloidosis has improved. Prognosis in ATTR amyloidosis is generally better than in AL amyloidosis, though both forms of the disease still carry a high annual mortality. Next, I will talk about diagnostic imaging of cardiac amyloidosis. The diagnosis of cardiac amyloidosis is usually performed by endomyocardial biopsy. However, the invasive nature and related high-risk complications restrict its wide use in clinical settings. Recently, with the advent of innovative technique used for evaluating cardiac amyloidosis, non-invasive methods have become important, especially in earlier diagnosis, distinguishing typing, risk prediction, and response to treatment. For that, LGE and T1 mapping is the first choice for diagnosis. If they are positive, the next step for distinguishing type is technetium scintigraphy. The SCMR statement recommended T1 mapping due to its additional diagnostic and prognostic values in the assessment of diffuse myocardial disease. Especially for all patients with heart failure, mapping should be considered. What we should know about ECV, extracellular volume fraction. ECV increases in several diseases as native T1. Basically, please use the normal ECV value as 25%. Hematocrit for the calculation of ECV should be obtained. This slide compares the short axis SSFP cine corresponding native T1 maps, PSIR, LGE, and ECV among two patients. Top panel showed very high T1 values, transmural LGE, and high ECV values in a patient with cardiac ATTR, and bottom panel showed normal T1, no LGE, and normal ECV in a normal heart. As cardiac sarcoidosis, we reported the usefulness of feature tracking for cardiac amyloidosis. This case highlights that combination of technetium PYP uptake and reduced regional strain in the thickened interatrial septum may be specific for ATTR amyloidosis. For the PYP scintigraphy, the American Society of Nuclear Cardiology recommends the semi-quantitative assessment. Over 1.5 of heart to contralateral lung ratio at 1 hour after injection is positive for ATTR. Semi-quantitative visual score of greater than leaf uptake or equal at 3 hours are classified as ATTR positive too. PYP imaging in ATTR left and AL right confirms intense uptake in ATTR and none in AL amyloidosis. Bone scintigraphy enables the diagnosis of cardiac ATTR amyloidosis to be made reliably without the need for histology in patients who do not have monoclonal gammopathy. ATTR amyloid as a more purely infiltrative disease, whereas the AL type may be a dual pathology with both interstitial expansion and cell death. T1 elevation was lower in ATTR compared to AL type, while ECV elevation was more prominent in ATTR. For ATTR cardiac amyloidosis, technetin phosphate cardiac imaging also shows high sensitivity and specificity. I will introduce a new tracer, F-fluvedabem. This figure shows myocardial amyloid uptakes in both AL and ATTR amyloid patients. The left column is amyloid PET, the middle is CT, and the right is fused images in 3 representative AL, ATTR, and control subjects. I'm going to summarize both cardiac diseases. In summary, for cardiac sarcoidosis, CMR has some advantages for evaluation of cardiac sarcoidosis without radiation exposure and specific study preparation. So far, FDG PET has advantages for quantitative analysis of inflammation. However, MR T1 mapping has potential for evaluation of active lesions. Regarding cardiac amyloidosis, T1 mapping and ECV measurements are essential for diagnosis. Technetin PYP scintigraphy is a key modality to differentiate ATTR from AL. Thank you for your attention.
Thank you for your presentation, Dr. Noriko Manabe has made a diagnostic confirmed by CMR and a little bit with FDG and the potential for series delay enhancement. Thank you. And the next topic, Dr. Nguyễn Thị Hồ Nga from Vietnam. She is working at Chorai Hospital and radiologist as a speaker from 2014 national conference. And now she has many research for efficacy renal cyanosis in patients with oral candidiasis, and also 3 research another. And now Dr. Nguyễn Thị Hồ Nga will present the topic myocarditis disease. Dr. Nga.
Hello everyone, a warm welcome to my presentation. The topic today I present is about MRI of acute myocarditis. Contains overview 2018 Louis criteria COVID-19 and acute myocarditis. Overview: acute myocarditis is an inflammatory condition of the myocardium diagnosed by cytology, immunology, and immunocytochemistry. Incidence: the prevalence of myocarditis in the population is 8 to 10 per 100,000. In the group of patients with dilated cardiomyopathy, the rate of myocarditis can be up to 40%. At the Chorai Hospital, so that this rate is near 7 per 1,000. The clinical scenarios of myocarditis are very with mild symptoms to severe symptoms. As most of the we usually see the acute myocarditis head infarct with normal coronary artery. This is a clinical diagnostic for criteria for acute myocarditis according to ACS 2013 based on clinical symptoms, ECG abnormality, cardiac enzyme, imaging techniques with no coronary artery lesion. The gold standard in the diagnosis of acute myocarditis is pathology according to the Dallas criteria, in which acute myocarditis is divided into two types, active and polarized myocarditis. Endomyocardial biopsy is a difficult, invasive, dangerous complication, and only a few blood cancer can perform it. MRI is a non-invasive imaging tool with high sensitivity and accuracy in the diagnosis of acute myocarditis and is increasingly developed and widely used in clinical practice. In the pathogenesis of acute myocarditis, when an agent attacks the myocardium, it damages the myocardium in both direct and indirect pathways. According to the direct pathway, it can cause myocardial necrosis on MRI, so clarify contrast enhancement myocardial area injury native T1. In an indirect way, it activates the inflammatory chain reaction and coronal cardio edema and vascular permeability. Myocardial edema source increase T2 weighted, injury native T1, injury native T2, injury vascular permeability, injury may object of contrast iron in an early phase or increasing EBC. Outcome most acute myocarditis, small patient complete recovery, some cases progress to chronic myocarditis by dilated cardiomyopathy. Next, I would like to present the main features of the ASCI criteria on MRI in the diagnosis of acute myocarditis. The protocol includes scout, CNA, T2 weighted, stir, T1 map beam, T2 map beam, ECG, T1 map beam post contrast, LGG. Some of acute myocarditis signs that can be seen on an MRI include pregonal or global wall motion abnormality, pericardial effusion, T2 myocardial hyperintensity, native T1, native T2, include extracellular volume, only spot contrast enhancement, like gadolinium enhancement. This is a schematic diagram of the history of MRI in the diagnosis of acute myocarditis. In 2005, a multi-center by Peter Hornell documented based on of ASCI. In 2009, Original LLC was born, and 2018, new LLC improved to increase the sensitivity and specificity of MRI in the diagnosis of acute myocarditis. In the original LLC, acute myocarditis is diagnosed when there are two or three main criteria, including pregonal high T2 signal intensity or T2 weighted image or injury global T2 signal intensity ratio, injury only gadolinium enhancement ratio on T1 weighted images, and other areas with high signal intensity in non-ischemic distribution based on play gadolinium enhancement. 2018 LLC consists of two main criteria, T1 by criterion and T2 by criterion. T1 by T1 is considered to be positive if there is an inquiry of negative T1, an inquiry of EPC or positive LGG exit. T2 by the T1 is positive in case of inquiry negative T2 or in cases with regional high T2 signal intensity on T2 weighted imaging or increase global T2 signal intensity ratio. Experiment of focal myocardial signal hyperintensity amplitude weighted is more sensitive than measure the T2 signal ratio, but depends on image quantity, experience radio loaded. In the several study of acute myocarditis shown in the table, it's found that the T2 signal ratio of myocardium increased 2 times compared to skeletal muscle at low sensitivity. These things could be explained as the borderline myocarditis is less edema on T2 weighted. In addition, with focal myocardial lesion, the full void can produce false negative. Another hypothesis in this scenario, when the myocardium and skeletal muscle are inflamed, can make the ratio become pseudonormal. Only by contrast, enhanced myocardium size compared with skeletal muscle also have low sensitivity. The causes are similar to the T2 ratio, signal ratio. Gadolinium enhancement is the most important sign on MRI with the highest sensitivity and specificity when considering its size alone. Gadolinium is an extracellular contrast. After intravenous administration, the contrast reveals the interstitial space within will finish. Most of the contrast diffuse into the blood to excess by the kidney. In case of an ongoing mitocyte necrosis, the contrast accumulates also inside the monocyte. The greater amount of contrast leads to an increased signal on T1 weighted imaging. In pregnant with excessive interstitial fibrosis, the light gadolinium remains intrepid in the fibrous matrix from where they are washed out in much longer time. Therefore, the pregnant with fibrosis remain whiter for a long time. A kinetic representation of hyper-enhancement basins that are characteristic for ischemic and non-ischemic disorders. Note that the area of hyper-enhancement in ischemic cardiomyopathy also includes the subendocardium. In fact, mid-wall or epicardial hyper-enhancement strongly suggests non-ischemic etiology. Under cleft contrast enhanced myocardial size has high sensitivity and specificity. It not only reflects acute myocardial necrosis, but also occurs in chronic fibrosis and scarring. Therefore, it is necessary to combine this site with other sites in MSC to diagnose acute myocarditis. Basins of myocardial and LGA midwall, epicardium and epicardium basin. T1 mapping measure the longitudinal or spring-plated relaxation time. Normal native T1 failure are specific to the local setup. In T1 so the condition which there is an injury in the interstitial space with or without edema. Low T1 failure is often seen in iron or lipid overload. This is T1 mapping image in normal basin. Where we can see the increase of myocardial signal in this T1 mapping image. The increase of signal in T1 mapping has 78% to 85% sensitivity. This is the equation to measure ECV based on the value of T1, free and both contrast injection and also the hematocrit at the time the MR was taken. EVC is a marker of myocardial tissue modeling and provides a physiological indicative unit of measurement. Increased EVC is most often due to excessive collagen deposition. Low EVC values occur in thrombus and fat liver metaplasia. This is the EVC mapping normal case. We can see the homogeneous blue ocean demonstrated in the image. And here with the myocarditic case, the myocardial signal has an increase of EVC. This side had sensitivity of 45% to 70% in some studies. Tito realization time is referred to as bins or transfer realization time. Inflammatory Tito indicates myocardial edema caused increased Tito, such as acute myocardial infarction, acute myocarditis, stress cardiomyopathy, sarcoidosis, and cardiovascular recession. This is the frequent of myocardium that is hyperintensive on Tito mapping corresponding to the frequent on LGA. The site has a sensitivity in the range of 62% to 79%. This is a report in 2019 about comparison of original and 2018 luxury material for diagnosis of acute myocarditis. The site did not have any significant difference between two groups of acute myocarditis and healthy control group, including T2 signal ratio, ECG ratio, EVC. Site with a significant difference between two groups of acute myocarditis and healthy control group includes visible myocardial edema, visible LVC, native T1 and native T2. Research author recommends cutoff on 1.5 guideline between as follows: T1 native higher 1000 milliseconds, EVC higher 28.8%, T2 higher 55.9 milliseconds. In this study, the original LLC and the 2018 LLC have an equally high specificity, and 2018 LLC is more sensitive than the original LLC. In the consideration, we see the LGG native T1 and native T2 have higher accuracy compared to the rest. The accuracy of 2018 LLC is 90% higher than original LLC had 81%. The study concludes 2018 LLC provides a high diagnostic accuracy with a significantly increased sensitivity compared with the original LLC. In summary, 2018 LLC have high value and high accuracy in clinical relative to diagnose acute myocarditis. COVID-19 has become a worldwide pandemic, although primarily affecting the respiratory system. COVID-19 associated myocardial injury is common and can occur directly due to myocardial virus infection and indirectly. Besides myocardial infection, acute myocarditis can also be a precursor of myocardial injury. In a pivotal conducted in Germany 2020 study on 8 patients with COVID-19 myocarditis and 8 patients with non-COVID-19 myocarditis, also with the normal control result so that most of patients have myocardial edema present as hyperintensity on T1 and native T2. Only 38% of COVID-19 patients had by contrast in hand lower than the myocarditis group without COVID-19 infection at 88%. A study in China, the results show an entry in native T1 account for 96%, native T2 accounted for 88%, but only 4% LGA. Result indicates in patients with early-stage COVID-19, myocardial edema and functional abnormality are driven hiding, while irreversible renal injury such as necrosis may be infrequent. Another study in Germany, in the study, it showed that 60% patients in pre-born native T1 and T2 consistent with the 2018 LSD clinical scenario of myocarditis, and 32% had LGE. The present author of this study recommends the need for ongoing investigation of a long-term cardiovascular consequence of COVID-19. In summary, MRI on a group of patients with suspected acute myocarditis is necessary. Quick-Lewis criteria has high sensitivity and specificity in the diagnosis of acute myocarditis. Thank you for your listening. I hope the conference is going well. Goodbye.
Thank you, Dr. Nguyen. That was a fantastic review of myocarditis, the different types and different criteria that one can use to review it. Our fourth speaker is Dr. Leju, who is going to be speaking on the role of CMR in heart failure, which is an extremely important and pertinent topic in these days. Dr. Leju is a professor of radiology in Beijing Anzhen Hospital, Capital Medical University in China. He has more than 60 peer-reviewed papers. His most recent paper, interestingly, is on deep learning for diagnosis of chronic myocardial infarction in non-enhanced CMR, and he has also got multiple papers in cardiac CT. Over to you, Leju, for your talk on CMR and heart failure.
Hello everyone. I'm very glad to attend this congress. Thank you very much for your invitation. My name is Lei Xu from Beijing Anzhen Hospital, Capital Medical University. The title of my presentation is The Role of CMI in Heart Failure. Heart failure still remains one of the most common causes of death in the world. Approximately 50% of patients diagnosed with heart failure will die within 5 years. Heart failure results from heart structural remodeling, including myocardial cell injury, such as hypertrophy, necrosis, or apoptosis, and myocardial fibrosis. Cardiac MRI is the best imaging modality for the diagnosis and assessment of prognosis of patients suffering from heart failure. CMR provides one-stop shop for the evaluation for cardiac morphology, function, tissue characterization, and myocardial fibrosis. CMR is the gold standard for the assessment of cardiac morphology and the global and original function. This is a case of dilated cardiomyopathy. CMR enables accurate wall motion analysis, evaluation for ventricular volume, myocardial wall thickness, LV and IV geometry pattern, and ejection fraction. CMR provides also a superior characterization of subclinical myocardial dysfunction with the use of string analysis. Feature tracking is a post-processing method which can be applied to routinely acquired CNA images and allow the detection for impaired myocardial strain in heart failure with preserved ejection fraction. This is the patient with ischemic cardiomyopathy. The delay enhancement in the posterior lateral wall, the impaired longitudinal strain is evident in the red color. Both eye shows the 3D longitudinal strain impairment in the red colored, red coded, and in the inferior and the lateral wall. The early impaired cardiac function can be identified by strain analysis. MR strain imaging is valuable for the assessment of heart failure with preserved ejection fraction and LV diastolic function, providing useful information for prognosis evaluation. This is the comparison of patient with heart failure with preserved ejection fraction and health control. LVEF is normal in both subjects. However, LV global longitudinal strain and LA strain is substantially lower in patients with heart failure with preserved ejection fraction. Study shows LV longitudinal strain assessed with CMR is an independent predictor of survival in patients with dilated cardiomyopathy. Myocardial infarction and fibrosis can be accurately imaged using late gadolinium enhancement. The differences in T1 relaxation time can be exploited between normal and injured or fibrotic myocardium after injection of gadolinium for 5 to 10 minutes. The myocardial infarction can be precisely identified on LG imaging. The bright signal is myocardial infarction. In ischemic cardiomyopathy, LG typically involves the subendocardium to transmural extension. The range and the transmural extent of the infarction can be evaluated, which can cause the adverse ventricular remodeling. CMR has a role in predicting contractile recovery after myocardial infarction. If the transmural extent is less than 50%, the likelihood of recovery is high. And if the transmural extent is more than 75%, no recovery can occur. LGE provides a prognostic value when compared to traditional risk factors. The presence of LGE is a strong and independent predictor of adverse cardiac events in ischemic cardiomyopathy. In the setting for acute myocardial infarction, microvascular obstruction, MVO, microvascular hemorrhage, and tissue necrosis can be identified with the CMI, and they are associated with poor prognosis. Microvascular obstruction, MVO, and the microhemorrhage can be identified in acute myocardial infarction. MVO is a diagnosis with low signal intensity within the hyperenhancement of infarction. The hemorrhage is diagnosed with low signal intensity on T2VT image and or T2 star mapping. So importantly, they are all associated with poor prognosis. CMR can help to differentiate the etiology of non-ischemic cardiomyopathy. CMR plays an important role in the risk stratification. In hypertrophic cardiomyopathy, the extent of LGE potentially plays a major role in sudden cardiac death stratification, increasing the risk of ventricular tachycardia. The fibrosis is a key independent risk factor associated with high MACE and poor prognosis in non-ischemic cardiomyopathy. LGE provides a unique non-invasive assessment of scar or fibrosis within the myocardium. And this is the extensive left ventricular mid-wall replacement of fibrosis in dilated cardiomyopathy, and the delay enhancement of fibrosis is identified in the mid-wall of the septum and the lateral wall. LGE patterns is particularly helpful in differential diagnosis between ischemic and non-ischemic cardiomyopathy. In non-ischemic cardiomyopathies, LGE may involve the endomyocardial, the mid-myocardial, and or subepicardial layers in different disease entities. This is the different enhancement patterns in different cardiomyopathies. CMI plays a key role in the diagnosis of this disease, such as amyloidosis, lobular endocarditis, hypertrophic cardiomyopathy, dilated cardiomyopathy, sarcoidosis, myocarditis, and ARVC. T1 mapping for tissue characterization can identify the underlying etiology for heart failure. T1 is commonly prolonged with fibrosis, edema, and infiltrative disease such as amyloidosis, and reduced in lipid or iron deposition. This is an example of prolonged T1 in cardiac amyloidosis and acute myocarditis, and reduced T1 value in fibrotic disease and iron overload. Myocardial tissue is approximately composed of 75% of myocardial intracellular tissue, which consists of the myocardial cells, the other cells, including the blood cells, whereas 25% consists of extracellular volume, ECV, with the space between all cells, the space between all cells, the space between myocytes and other cells and the blood cells. By measuring the myocardial and blood native T1 before and after administration of contrast agents, as well as the patient's hematocrit value. The cardiac extracellular volume, ECV, can be quantified according to this formula. The left ventricle undergoes remodeling during the process of heart failure. The microstructural remodeling becomes more severe as the stage of heart failure, with increased diffuse interstitial fibrosis. The diffuse myocardial fibrosis is associated with ventricular function impairment in patients with heart failure. LGE can detect focal fibrosis. Diffuse fibrosis cannot be detected on LGE because of no normal myocardium for comparison. ECV is considered a marker of the extent of interstitial fibrosis. Diffuse fibrosis can be quantified by CMI extracellular volume. The clinical application of T1 mapping and ECV include the etiology diagnosis of heart failure and the prognosis evaluation. Detecting the changes in ECV may allow clinicians to quantify the severity of disease, determine the prognosis, and establish an early diagnosis for heart failure. This is a representative case of T1 mapping, ECV, and end-diastolic cine imaging in normal and healthy aging stage A and stage B heart failure, including heart failure with preserved ejection fraction and heart failure with a reduced ejection fraction. So you can see the significant increase in the extent of native T1 and the ECV representing the increased interstitial fibrosis. This is the study of T1 mapping and ECV for cardiovascular outcome in dilated cardiomyopathy. Patients with elevated ECV experienced significantly higher adverse clinical outcomes than patients with lower ECV value. CMI plays an important role in the diagnosis and prognosis of myocarditis. Myocardial edema can be identified by T2 mapping. T2 star mapping allows the quantification of cardiac iron levels. The diagnosis and the prognosis can be determined by T2 star mapping. If T2 star was less than 10 milliseconds in myocardium, thalassemia patients will develop heart failure with increased LV dysfunction. T2 star mapping allows the evaluation for severity of iron overload. And this is the T2 star mapping in a normal patient, a patient with mild iron overload, and a patient with severe myocardium iron overload. Heart failure evolves from asymptomatic forms with subclinical LV dysfunction, that is stage A and stage B heart failure, and towards progressive diastolic or systolic dysfunction, stage C and stage D heart failure. The stages of heart failure can be determined with CMI techniques, including cine imaging, string analysis, LGE, T1 mapping, and ECV. This is the clinical staging for chronic heart failure. The stages of heart failure can be determined by the different signs and the parameters of CMI, including the morphological and the functional parameters. Some of heart failure with preserved ejection fraction have no hyperenhancement or LGE, but T1 mapping and ECV can identify the diffuse fibrosis, so including the indicating the early functional change. Diffuse myocardial fibrosis impair the diastolic function. So ECV quantification is of great value to heart failure with preserved ejection fraction. CMR can help risk strategies in subclinical heart failure. The evaluation for left atrial morphology, function, and strain is helpful in diagnosis of heart failure with preserved ejection fraction. CMR is a promising technique in guiding LV lead placement for CRT. 30% of CRT do not show clinical improvement, a larger scar burden, and fewer viable myocardium associated with non-response to CRT. The location of scar tissue within the myocardium may play an important role for the response to CRT, and the presence of scar in septal or posterior lateral wall significantly decrease the response rate to CRT. And several studies have shown lower CRT response when the lead is placed in scar tissues on LGE. In summary, CMR is the gold standard for measuring cardiac chamber size, volume, and function. CMR enables accurate wall motion analysis and anatomical functional valve evaluation. T1 and T2 mapping for tissue characterization can identify the underlying etiologies of heart failure. And LGE provides useful and unique non-invasive assessment of scar or fibrosis. And ECV and strain analysis can evaluate the early stage of heart failure. CMR will continue to play a key role in the diagnosis, therapeutic strategies, and the prognosis of patients with heart failure. Thank you. Thank you very much for your attention.
Okay, thank you, Professor Lei Xu, has to present for the role of CMR in heart failure. In the time, we have terminated four topics for cardiomyopathy essential, and now we move to Q&A session. Because Dr. Karen, Dr. Nga, and Dr. Lei Xu could not be online, and that's why we have only Dr. Noriko. Please, any audience have a question? Okay, Dr. Sanjaya has the comment.
Thank you. We've had an excellent session. We've heard a lot about different forms of CMR, and we've also heard a lot about different types of imaging. Dr. Noriko, you mentioned the use of both cardiac MR and PET imaging, and you gave us some advantages and disadvantages of both. If you are in a department which has access to both PET imaging and CMR imaging, what would you suggest in terms of triaging a patient towards CMR or towards PET imaging for both sarcoidosis and amyloid? When would you suggest one should be used over the other?
Okay. In my institution, actually we have two modalities, CMR and PET, and we use CMR as a first gatekeeper for cardiac sarcoidosis. So if you have any abnormal wall motion or LGE, and if it's a kind of typical LG pattern and suggested cardiac sarcoidosis, we recommend the physician to order PET as a next step.
Okay, I hearing from you. You have a demonstration with sarcoidosis on SCD, FDC 18, and the CMR. And also, they mentioned about the delay enhancement on CD. Very interesting. Could you be explain more for audience to understand?
Okay, so if the patient has implantable devices and if it is not MR compatible, we should use CT instead of CMR. And for delayed enhancement, as you know, CT delayed enhancement also very useful for diagnosis of cardiac sarcoidosis. But for that, we need kind of a large amount of contrast media, about 600 milligram yodo per kilogram. So it's a kind of big amount compared to coronary CT angiography. So we need to be careful about the contrast amount.
And you should be use stress or not? Because the perfusion CD will be red and stretch phase in the CMR for CT to demonstration for lesion of the sarcoidosis. You use similarly with evaluate for perfusion CD.
Excuse me, so what do you mean? So are you asking about the protocol of CT or?
Yes, the protocol of CT, because if we should be evaluation for perfusion CT will be done by two phase, red and stretch. And if you ever in sarcoidosis for delay enhancement on CD, you will have a protocol same or you have to call other.
If we doubt whether the patient has cardiac lesion for sarcoidosis patient, we use the whole body enhanced CT first, and then after 5 or 10 minutes, we add additional delayed enhanced ECG gated cardiac CT for delayed enhancement.
Yeah, okay. And comment from Dr. Sanjaya. I see you.
Finally got my video working.
Yeah.
So, Dr. Noriko, do you have any experience in using CMR for treatment-related changes for prognostically following patients with amyloid, particularly the ATTR variety, which has got 1 or 2 small clinical trials in terms of medication?
Yes, actually, I have very few cases before and after treatment for cardiac amyloidosis. But another patient with congestive heart failure, we follow up the patient several times and to see the myocardium edema. In that case, we can follow the T1 value changes, and after adequate therapy, the patient improved LVEF and T1 value was improved. So maybe it might be available for cardiac amyloidosis patient, but in that case, I think only myocardial edema effect on the T1 value. So I'm not sure about amyloid deposition.
And in your department, you use other example for T1T2 mapping, etc. You use some time for PCIR to evaluate rather than.
So, are you asking about other diseases?
Yeah.
Not only cardiac sarcoidosis, amyloidosis.
Okay.
Okay. Actually, for myocarditis, we use T1 mapping, as other doctor presented.
Okay, thank you.
One last question, if I may ask, is do you use train imaging? And does that help you, again, in terms of, not just in terms of diagnosis, because that's mostly LGE related, but does train imaging have any role in either amyloid or sarcoidosis or any other form of infiltrative cardiomyopathy from your experience?
Okay, it's very important question, and thank you for asking. So now why I use the strain imaging with feature tracking. As you know, feature tracking, you can use existed cine imaging. So it's very easy and does not require any extra scanning for strain imaging. And actually, for cardiac sarcoidosis, we need to know the existence of RV involvement. So for RV evaluation, sometimes LGE is difficult because it's very thin wall. But for strain imaging, if in my presentation, I showed my case report just published this year, and for RV, very regional wall motion abnormality can be very helpful to find RV involvement in cardiac sarcoidosis. So I would recommend if you can use feature tracking evaluation of RV, you can find extra abnormal findings from feature tracking.
Thank you. Dr. Noriko has a presentation and answer the question. And now the time we end the session. One more time, we would like to thank Dr. Noriko has just online just at the end of time. Dr. Sanaya has participated with our team, and also sincere thanks all participants on this session. Thank you.
Thank you.
Bye-bye.
Have a good night. Bye.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.